still waiting for the Professor Sabri to join and to check the sound.
Good morning, Prof. Tania.
Good morning, Dr. Sandi.
So you'll be the first speaker.
Okay, I'm ready.
Thank you. We're gonna start in 2 minutes.
Yeah. And we also still wait for Professor Sabri because he already joined, but I have the audio problem. I hope he can join in time.
Or we can switch if.
Yeah, probably we can switch to the last presenter.
Okay.
2 minutes ahead.
Yes, two more minutes. And I don't see Dr. Oki. Dr. Oki is still here, right? Yeah.
Dr. Okay, probably you can move your handphone to the landscape mode so the video will become more wider.
Landscape.
I'm so sorry, doctor, because this time I'm double device, so I just can just portrait. But later I can move to landscape mode.
Okay, thank you.
I'm sorry.
Okay. Hello, Professor Sabri. Can you test your microphone?
Hello, Assalamualaikum. Can you hear me?
Waalaikumsalam.
Wow.
Very clear.
So sorry.
Alhamdulillah. Thank you.
Alhamdulillah.
Alhamdulillah, Prof. Sabri, welcome.
Yeah, it's my pleasure to be here. Yeah.
Okay. Thank you. Okay, we may start the meeting.
Yes. Dr. Asa, izin. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. It's a pleasure to meet you all again at the APAN58 with the Telemedicine Development Center of Asia, TEMDEC, in collaboration with Faculty of Dental Medicine, Universitas Erlangga. So we proudly present a dental telemedicine session in Asia Pacific Advanced Network 58 with the topic Empowering Asian Dentists on Comprehensive Pediatric Dental Management. I'm Sandy Sumardi, and today I'm going to introduce all the speakers. We have 4 speakers today from the dental aspect. It's Professor Tania Saskianti from Universitas Erlangga, and Professor Sabri bin Musa, University Malaya, and Dr. Amrita Widyagarini, Universitas Indonesia, and Dr. Mitsuko Chiba from Kyushu University. And without further ado, we're going to start the first session, and it will be by Professor Tania Saskianti from Universitas Erlangga, with the title of Anemia as a Convoluted Cause of Pediatric Drug-Induced Erythema Multiforme, a case series. So Professor Tania is already famous by being with the focusing on the research in stem cell, and the latest project is with the BMP, the bone morphogenetic protein. And also, she is seeking the new natural compound for preventive medicine of periodontal disease by regulating the inflammatory response in gingival epithelium. At this moment, she's also the coordinator program study for specialists in pediatric dentistry. So without further ado, we have this 15 minutes session, Professor. The time is yours. Thank you.
Okay, thank you very much, Dr. Sandy. So let me share the presentation first. Okay, can you see my slide clearly, Dr. Sandy?
Yes, it's
Okay.
clear.
Okay, thank you very much. Assalamualaikum. Good morning, all the audience of 58 APAN meeting. Greeting from Surabaya. My name is Tania Saskianti from Universitas Erlangga, and I will present a case series discussing anemia as a convoluted cause of pediatric drug-induced erythema multiforme. So we are on the first case. We here present a 3-year-old male patient with chief complaint of blood encrustation on his lips for the past 1 week. And he gave history of sore throat, of which he received spiramycin and dexamethasone. Subsequently, he developed a multiple small ulceration that later transformed into extensive and hemorrhagic crusted lesion on labium superior and inferior oris without expansion on oral mucosa. On palpation, bilateral submandibular lymph nodes were enlarged and tender. Patient then instructed to discontinue the prior medicament, and we managed the difficulty eating and discomfort by saline debridement on the first visit. Saline will allow the blood encrustation soften in the affected area, while the saline also facilitates removal of necrotic tissue as well as help reduce inflammation. And also we then prescribe an antihistamine and also ibuprofen syrup. We suggest the parents to do the home saline debridement 3 times a day. So, and on the 3rd day, reduced pain was admitted, but the blood encrustations also slightly reduced, but the swelling and redness still persisted. The patient was then instructed to stop the antihistamine and analgesic. We then prescribe a topical antibiotic and steroid 3 times a day, consisting hydrocortisone, lanolin, chemicitin, and also Vaseline. On day 8, some parts of blood encrustation on the lower lip border was disappeared. There was no pain, no swelling, nor active bleeding reported. The patient was able to eat comfortably. Blood encrustation was completely disappeared on day 14, but desquamation on the upper lips still extend. And we suggest to stop the antibiotic and topical steroid. And we instructed the patient to apply chlorine dioxide gel 2 times a day to maintain lip moisture and prevent dryness. Unexpectedly, on the day 24th, exfoliative lesion of cheilitis appeared again on the upper and lower lip. And as new types of lesion appeared, a complete blood test was performed. So here we see that a complete blood test indicated a low hemoglobin level with the morphology of microcytic hypochromic erythrocyte. The patient was then referred to pediatrician for further examination. So based on the low iron serum level and a very high TIBC level, total iron binding capacity, the diagnosis was then lead to iron deficiency anemia. Iron oral supplement was then administered. Then the patient responded well to the treatment. Lesion was perfectly healed 2 months after the first visit, which is a very long time. And the patient was strictly advised not to take antibiotic consisting of spiramycin or other macrolide combined with dexamethasone. We diagnosed the drug-induced erythema multiforme based on the positive correlation between drug consumption and the occurrence, as well as the clinical appearance of the lesion. Here we also present the second case of 2.5 years old female patient with the chief complaint of itchy and desquamative blister on her lips. Lips ulcer will bleed, and erythema also present around the encrustation. We didn't find any abnormality in the pharyngeal and laryngeal examination, as well as the neck nodes were not palpable. In the personal history, 1 month ago, the patient was infected with chickenpox. The symptoms was resolved, but the fever was arise again 2 weeks ago, and then the patient was received spiramycin and dexamethasone when she came to our hospital. Interestingly, this second patient is the neighbor of the first patient, so they receive similar prescription from the same health service. So based on our experience with the first patient, we suggest the parents to give the patient a healthy diet and make sure that the patient get enough sleep to boost the immune system. And CBC analysis shown the increased lymphocyte count that indicate the patient body is dealing with the infection or any other inflammation condition. The treatment was then started with the topical triamcinolone acetonide, vitamins, and also antihistamine syrup. This photo was taken by parents' mobile phone on day 3 and day 5. Under these therapeutic measures, the active cutaneous lesions show regression on the 3rd day without no flares, and then the clearance of the lesion was then maintained on the day 5th. So positive response of the treatment was shown is so different healing with the first patient. So for this patient, the serological analysis was excluded. And based on the sudden onset and then the positive drug history, the extensive ulceration of the oral cavity, cracking and fissure of lips with the bloody crusting will lead to the diagnosis of oral erythema multiforme. So erythema multiforme is an inflammatory disorder that affects the skin or mucous membrane or both. Yeah? Based on the severity and the number of the mucosal site involved, the disease has been subclassified into erythema multiforme minor and also major. The oral erythema multiforme is the new category of erythema multiforme without any skin lesion. However, the subsequent attacks can produce more severe form of erythema multiforme involving the skin, and hence it is important to identify and distinguish them from other ulcerative disorder involving the oral cavity for early management and proper follow-up. When the lesions are confined only to the oral cavity, the differential diagnosis that has to be considered are herpes or autoimmune vesico-bullous lesion or other patterns of drug reaction. Our patients show advanced ulcerated lesion, and then the diagnosis has to be established based on the positive drug history, their clinical appearance and distribution of the lesion, and exclusion of other ulcerative lesion. The oral ulcerative, in our cases, started within a few days of the drug intakes and were resolved upon the cessation of the drugs. So we were able to establish a temporal relationship between the drug intake and occurrence of the oral mucosal lesion. And it helps us to distinguish them from the other ulcerative disorder. In a prolonged case, like our first case, the laboratory analysis, including CBC or the serological, are advised, but the decision is likely best made after consultation with the expert. The initial stage of the disease are generally treated symptomatically. Supportive therapy is most based on the history and examination. During the severe case, when the oral mucous membrane are involved, to suppress the cytokine and chemokine response, adjuvant therapy with steroid are suggested. But for the children who present with signs of herpes infection in early onset, we suggest to give the antiviral treatment to reduce the severity and also duration of EM eruption in some children. If when the oral mucous membrane are involved or when the children are systematically unwell, in a very deep pain or experiencing considerable discomfort, the admission to hospital for hydration should be considered. Anemia, like a fever, it is not a diagnosis, but a presentation of an underlying disease. Anemia can be defined as a reduction in hemoglobin. In our patient was 10.2 with the morphology of microcytic hypochromatic erythrocyte. The microcytic anemia happen when your red blood cells are smaller than usual because they don't have enough hemoglobin, which is the low hemoglobin level can slow the wound healing. Iron supplement may help get rid of the underlying cause, and our second patient was responded well to the treatment. Oh, sorry, the first patient. So, no form of therapy is an eminent as widely effective. However, early management and proper follow-up is important to prevent the subsequent attacks that can produce more severe form of erythema multiforme. So this is our conclusion, and our case discussion can be read in detail soon in Journal of Dentomaxillofacial Science. And here is the references. Big thanks to all the pediatric dentistry residents and staffs as well as our external collaborator, Prof. Lily from University of Malaya, for our teamwork. And thank you so much for your attention.
Thank you so much, Prof. Tania. A very prompt presentation and a very great presentation. And I would like to present the second presenter. We have Professor Dr. Sabri bin Musa, and he's from Department of Pediatric Dentistry of Orthodontics, Faculty of Dentistry, University Malaya. And he has many publications, and including about the ACDAS, which is the ABIR Children Dental Anxiety Scale, Cross-Cultural Adaptation and Validity of Self-Report Measures in Malaysian Children Context. And today, we're going to have a very good opportunity for the presentation from Professor Sabri with the title of Comprehensive Dental Management of a Child with Congenital Heart Disease. Thank you so much for being here, Professor, and the time is yours for 15 minutes. Thank you.
Thank you so much, Mr. Chairman. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and very good morning to everyone. You all can hear me?
Loud and clear.
Right, thank you. It's nice weather here in Kuala Lumpur, Malaysia. And thank you for giving me an opportunity to share the case study from Malaysia, Kuala Lumpur, University of Malaya, on comprehensive dental management of a child with congenital heart disease. And this patient, aged 10 years, 1 month, as female Malay patient, was referred by pediatric cardio to our faculty. Overall treatment's been done for her is about 11 years, 3 months, as what's being reported here. She did complain of pain in the lower right back tooth, and history of complaint. The recent episode was 1 week ago during the day that she came to see us. Pain disturbed sleep, took paracetamol to relieve the pain, and denied history of facial or gum swelling. And I highlighted the important details. Of course, the family history, everything's been taken to check, but important to highlight that from the social history that she's from the lower socioeconomic family and diagnosed with double inlet left ventricle transposition of great arteries and pulmonary stenosis since birth. And she has gone through a few surgeries and multiple cardiac surgeries. What I mean is Blalock thoracic shunt at birth, Glenn shunt at 3 years old, and Fontan procedures at 7 years old. And other relevant history is comprehensive dental treatment has been done for her under general anesthesia at the age of 6 years prior to Fontan procedures, and irregular toothbrushing, not supervised, often consume chocolate, junk food, and carbonated drinks. A slightly short stature is to highlight it here when we first time look at her. And Frankel behavior scale 3, and nevertheless is anxious towards procedure or apprehensive towards the dental procedures. And the extra oral examination been done, symmetrical face, class 1 skeletal pattern, insufficient mouth opening. As I mentioned earlier, she's a bit short stature for the age of 10 years. And intraoral examination also been done, as we've seen here. The intraoral examination that has been done. All inside the mouth is permanent teeth. There's no deciduous teeth. Of course, I think she had that surgery under general anesthesia to remove all the decay before that Fontan procedure for heart. I suppose all the deciduous teeth being removed at that time. And at present, at 10 years old, she's presented intraorally with all the permanent teeth only, and very poor oral hygiene when we saw her, and the site of complaint, the tooth is 4-5 is retained root for the site of complaint here, retained root of 4-5, and no sign of infection. And 214 with yellowish brownish here, 14 yellowish brownish, and grossly decay. 212 demarcated creamy white opaque on the labial surface, and 26 the same thing but is occlusal surface here, demarcated opacity. Sorry. And deep palatal fissure on the teeth 1, 2, and 2-1. Sorry. Okay, and anterior crossbite between teeth 1, 2, and 4-2 with gingival recession here, which is about 2 millimeter, the labia of tooth 4-2. And after that, we do the special investigation. We took bite wings, and from the bite wings, we can see that the 1-6 is there's a decay, and 1-4 also there's a decay, yeah, and 2-4-6 we can see the, maybe it's not quite clear here, but radio opacity indicating restoration extending outer 1/3 of the dentine here, outer 1/3 of the dentine. It can be seen quite clear because this is she had the glass enamel cement restoration. And for the upper right, same thing, there's a developing 1-7, 1-5, and 1-3, and for the periapical radiograph that we took, there's a developing again 1-7, 1-5, 1-3 is quite clear, and 2-1-6 radiolucency involving inner third of the dentine is quite clear, and no periapical pathology, luckily, and 2-1-4 radiolucency involving the pulp, periapical redundancy with root resorption, as we can see here. This is the tooth 1-4, and we took the dental panoramic tomography (DPT), and then from DPT it can be seen that all permanent teeth and unerupted permanent tooth germ are present, complete. The set we can see the initial classification of 3A and 4A here, and there's no other pathological noted on the upper as well, and the lower is the same thing. Left buccal segment is a bit crowding. The buccal segment is a bit crowding there, and also no other pathological is noted. And from there, we come up with the diagnosis that multiple dental caries, molar incisor hypomineralization of teeth 1-6, 2-6, and 1-2, tenuous tooth 1-4, and anterior crossbite between teeth 1-2 and 4-2, and posterior crossbite between teeth 1-6 and 4-6, and upper left buccal segment with severe crowding, and lower left buccal segment moderate crowding. And the aims of and objective of treatment for this patient is to render patients free of dental pain and infection, as she first came to us to complain of pain in lower right area of the mandible, to manage molar incisor hypomineralized teeth, to control caries or to prevent caries progression and new caries development, to optimize oral hygiene practices, because the oral hygiene is not as what we expected or we like to see, and to correct anterior crossbite to prevent traumatic occlusion, because there's a reverse overjet between the tooth 1-2 and 4-2. And the treatment plan for this patient is for prevention, as all the PEDS dentists must do for their patient, is oral health education and dietary advice, full mouth prophylaxis, polishing, topical fluoride varnish application, fissure sealant on teeth 1-1 and 2-1 because the very deep fissure on the palatal of these two teeth. And rationale is noted there for the treatment plan, increased caries risk and then a deep palatal pit on the teeth, 1-1 and 2-1. And the intermediate plan is to do interim therapeutic restoration on tooth 1-6 with class I normal cement and liaison with the pediatric cardiology for international normalized ratio INR regulation prior to tooth extraction. Just to highlight it here, the patients undergone warfarin therapy because of a condition and daily intake of about 2.5 milligram warfarin therapy to liquefy the blood. So we have to be careful if you want to do extraction for this sort of patient. So the liaison, we got to know what is the ratio of INR when we want to do extraction, because we don't want any excessive bleeding after the extractions. And the definitive treatment for her is to do preventive resin restoration on teeth 2-6 and 3-6, and stainless steel crown on tooth 1-6, composite restoration on teeth 1-1 and 4-6, extraction of teeth 1-4 and 4-5 with infective endocarditis prophylaxis. And for orthodontic pediatric combined clinic, maybe we can suggest it for interceptive orthodontics with upper removable appliance, or if they can accept removable appliance, we can suggest for fixed appliance. And long term is to regularly do the review 3 monthly and 6 monthly with the radiographic review, because this patient categorized under high caries risk, and monitor growth and development, also eruption of the permanent teeth, because there's a risk of buccal segment crowding. The treatment progress. It took about 14 visits actually to complete the treatment under normal dental chair, because she also got history of not reliable, because at the beginning she seek dental treatment at Hospital University UKM, the other hospital university, instead of University of Malaya, but he default few visits. And when was referred by PEDS cardio, they gone to PPUM, which is the University of Malaya Medical Centers, instead of follow up with the UKM. And the PEDS cardio referred to us, the oral hygiene education and dietary advice, full mouth prophylaxis, fluoride varnish application, diet diary, and liaise with pediatric cardiology teams for extraction of teeth 1-4 and 4-5 was planned, arranged for from the beginning of the visits. And after that, the restorations been done, or the required as what been planned of the definitive treatment that been discussed earlier. And we issued the upper removable appliance on the 8th of January 2024, which is about 8 months after completed all the necessary treatment. And final visits on 27th of June, full mouth prophylaxis and fluoride varnish application done. I will discuss into detail what's happening, highlighted what's important to treat this sort of patient. And these are the pre-treatment photo and the post-treatment photo that we had, whereby we did all the restoration that is needed, PRR, preventive resin restoration, plus the fissure sealant on the 1-1 and 2-1. On one seat, we do the stainless steel crown, but you can see the oral hygiene is not quite as we wanted, and all the PRR filling also on the 3-6 and 4-6, and but we keep motivate and re-emphasize on oral hygiene practice every time she came to visit us. Okay, pre-treatment radiograph also I highlighted here, and post-treatment radiograph to compare. Of course, after 1 year, it's slightly different. Some of the permanent tooth is erupted already, as compared to the first visit. And these are the photo of the upper removable appliance that we issued and to her after 8 months. Then we issued the appliance during the visit 11, yeah, sorry. We issued and then she skipped after about 1 month. She skipped the appointment, but we interviewed through phone with the mother. Mentioned to us that she's reluctant to wear the upper removable appliance due to the discomfort and also peer review, but we convinced the mom to bring her to visit us after that. Whereby she came in the month of April 2025. Yeah? And during that visit, we did re-emphasize do the prophylaxis and re-emphasize the importance of wearing the appliance. And reflective learning or discussion on congenital heart disease patient and their management. It is very important because this patient is diagnosed with the complex cardiac condition from birth, including double inlet left ventricle, transposition of great arteries, and pulmonary stenosis since birth. And of course, the patient had gone through lots of things and then maybe a bit apprehensive that been carried until she's at 10 years old. And she also been prescribed with warfarin and monthly international normalized ratio monitoring, whereby she got to come, and she's not really it's a good regular taken the warfarin that been prescribed according to the mother. And the second one is a molar incisor hypomineralization and dental caries. Yes, we diagnosed this with the cyanotic congenital heart disease at birth. There is an increase of susceptibility to molar incisor hypomineralization, and there's a presence of demarcated white opacity on teeth 2 seats and 1-2 led to the diagnosis of MIH. And during her initial visit, she's presented with enamel hypomineralization of the first permanent molar and multiple cavitated lesion on teeth 2 seats, 3 seats, and 4 seats, including smooth surface of caries on labial surface of tooth 1-1. So this observed that lead us to the diagnosing of the molar incisor hypomineralizations. And the tetanus tooth, whereby there is severe decay on tooth 1-4, likely resulting from the previous primary tooth that required extraction before. And due to she's in high caries risk due to her caries experience, poor oral hygiene, and also high sugary intake. For dental management in child with congenital heart disease with anticoagulant, they are at high risk for caries and serious medical complication due to oral infections. So it is necessary for us to liaise with our PITS cardiologist, whereby in our team in University Malaya Medical Center suggested to do the extraction when the INR is within 2.5 range, which we do it when she had a INR about 2.3. So then we extract the tooth, then Alhamdulillah, and there's no severe bleeding. The bleeding can be controlled accordingly. But of course, we need to give the prophylaxis antibiotic. You giving her the amoxicillin dosage for once before the extraction, half an hour before, and then the procedure going on as what we willing to. Then post-operative care was given to the mother. And for interceptive orthodontics, we discussed because of the crossbite, anterior crossbite of 1, 2, and 4, 2. We discussed with our orthodontic colleagues, and then we give 2 options to her to rectify the malocclusion, included using an upper removable appliance, or we fixed appliance later on, but we choose for the upper remover appliance first. And we do for that, but for the posterior crossbite, which is quite mild, a conservative approach was advised due to her ongoing growth. So no active intervention is planned for the severe crowding of the lower buccal segment. We try to rectify the anterior part whereby the crossbite of 1, 2, and 1, 2, and 4, 2 to be rectified. Yeah, and the 5 is important for us to, whenever patient came to us, we for this patient particularly, oral hygiene, we have to make sure the hygiene is satisfactory during the review in June 2024. But again, through my localization, gingivitis was observed on the maxillary anterior region. The 3 months follow-up was recommended for caries risk assessment and monitoring of tooth eruptions. And regular review was emphasized to ensure oral health is not neglected due to medical issues. So the conclusion is, for this case, the long-term monitoring is crucial for medically compromised patients to identify new caries and maintain oral hygiene standards. A multidisciplinary approach is essential for managing a child with congenital heart disease and anticoagulant therapy to ensure optimal care. And there is a need to address unmet dental care in medically compromised children. And I would like to acknowledge Dr. Chin Yuji, our postgraduate student, and all the academician and supporting staff at Department of Pediatric Dentistry and Orthodontics, Faculty of Dentistry, University of Malaya, Kuala Lumpur, in provided service for this patient. And with that, thank you. Terima kasih.
Dr. Sari Sandy? We cannot hear you. Oh, still mute from the, I don't know.
I'm sorry,
Okay.
Mr. Tunggul, could you please allow us to unmute?
Okay. Okay, already done.
Thank you. Can you hear me now?
Yes.
Thank you so much. I'm sorry for the technical problem. Thank you so much, Professor Sabri Musa. It's a very, very mind-blowing with meticulous treatment plan provided with special care with this patient. Thank you so much for your presentation. Next, we're going to have the third speaker, Dr. Amrita Widyagarani from Universitas Indonesia. Her presentation is titled by Interdisciplinary Approach to Dental Management of Down Syndrome Child. She's from Department of Pediatric Dentistry, Universitas Indonesia, and her major interest is immunology and special needs patient. And thank you so much, Dr. Amrita, for your time. And you may start your presentation.
Thank you so much, Dr. Sandy, for the nice introduction. So I will share my screen. Okay, good morning, Prof and doctors. My name is Amrita. I'm from Department of Pediatric Dentistry, Universitas Indonesia. Thank you for the invitation and the opportunity for us to present our case study. So I will introduce briefly about our faculty. So we have 2 locations of the dental hospital and university hospital. So first location is in Jakarta, is the capital city of Indonesia right now. And we have a dental hospital in Salemba campus, and also we have the university teaching hospital in Depok campus. Okay, so let's start with the background. So as we know, Down syndrome is a genetic disorder when a person will have an extra copy of chromosome 21. And this occurs caused by the abnormalities of cell division. And because of these genetic disorders, it will affect of the physical features and also the medical condition of the Down syndrome child. And like any other child with the special healthcare needs, Down syndrome child need receive support from the dental health professionals because they have clinical manifestation that related to the oral health. However, there are some challenges for these children to receive dental treatment. So first, Down syndrome child have the high prevalence of the medical conditions. And the second, the intellectual disability, which is common in Down syndrome child, it will affect the ability to cooperate in the dental office, the ability to or oral care. And some patients with Down syndrome child also co-occur with the behavioral disorder, so it will make more challenging for Down syndrome child to receive dental treatment. So in this study, a 3-year-old girl came to the Universitas Indonesia Hospital with the chief complaint that the child refusing to eat in the past 3 days. According to the parents worry that this caused by her teeth conditions, and the parents are unable to maintain the good oral care for her because she always refusing for the toothbrushing and she has the aggressive behavior. And in addition, she also had a bottle feeding in bad habit. She had not been receiving routine prescribed medication, and she regularly attended a speech therapy and occupational therapy. At the time, she has been done this therapy for 6 months. And in the first visit to the dental clinic, we observed her behavior. She was unable to communicate, showed a hyperactive and aggressive behavior, so she unable to cooperate in the dental setting. So we decided to have the dental treatment under general anesthesia. So after having consultation to the pediatrician and anesthesiologist, we refer her to the cardiologist to have the echocardiography, and the echocardiogram results show there were no ESD and also no VSD, but she has a little size PDA around 1.5 millimeters, and ventricular ejection fraction was in normal range, and the heart valves was normal. So if we look a figure on the left side, it shows the intraoral examination when she was being sedated in the OR. It showed multiple carious lesion on this child, and also show the characteristic of oral manifestation, hypodontia. She has missing lateral mandibular incisors. So all the dental procedures were done under general anesthesia as written on the slide. So we perform endodontic therapy, extraction, and restoration under DGA. And for the follow-up care, the parents were educated and motivated to brush the child's teeth. And the occupational therapy report said that the parents have homework to improve the child's tactile stimulation by introducing her with various textures during the bedtime. So this could be applied to introduce about various types of toothbrush that they can be used. Then we let the parents to choose and develop their preference techniques. So the patient is currently undergoing follow-up care. She comes every 3 months to dental clinic as an outpatient. On the 6-month follow-up, the parents complained that the upper tooth was broken after the child banged her head against the walls. And the child developed self-injurious habit. And parents also still struggling to brush child's teeth. And this time, we restore the first maxillary left incisor. And next, on the 9 months follow-up, as shown in the picture, we can notice the crack between the remaining tooth and also the restoration. The parents reported that the child keeps the self-injuries habit by banging her head against the walls or floors, and the parents are still struggling to maintain their child's oral care. So because of this uncontrollable behavior, we decided to refer the patient to a psychiatric, whether she will have the psychotherapy supportive or medication. So for the discussion, in this patient, the dental caries rate was considered high, which led to the diagnosis of severe early childhood caries. Although studies reported that DS have a lower prevalence of dental caries, but it may occur due to several risk factors. And the patient has a high risk of dental caries because they still had the nursing bottle habit. The parent was unable to maintain the child oral home care, and she also in the category of special health care needs patient. And the patient had an extensive caries lesion in a young age, and her mental condition made her unable to cooperate in the dental office. Therefore, this patient was recommended to receive dental treatment under general anesthesia for safety and efficacy treatment reasons. Intellectual disability is the most frequently clinical manifestation of DS. Behavior disorders are frequent in children with intellectual disability. And although DS children are known as a friendly, good-tempered, or affectionate, but they also show externalizing behavior such as tantrum, hyperactivity, inattention, agitation, and also the speech problems. And some reports also show that children with DS co-occurring diagnosed with the autism, ADHD, and other behavioral disorder. So to decide the suitable behavioral technique for this child with the special needs and also with the behavioral disorders, the dentist should understand the child's cognitive function, what the child likes and dislikes, and those information is important to build communication, relation, and trust between dentist and the child. And in certain cases or special cases, counselors or mental health professionals can help children or individuals with DS with the behavioral disorder. So in the Down syndrome patient, up to 50% of patients with DS have the congenital heart disease. And ASD and VSD are the most common congenital heart disease associated with Down syndrome. And children with congenital heart disease have a risk for infective endocarditis. So people with DS and congenital heart disease should attend regular dental care to minimize infective endocarditis. It means systemic conditions should be evaluated so the dental procedures can be carried out safely in this patient. Oral home care is essential to this patient. However, it was very challenging both to the parents and the child to build the toothbrushing habit because of the behavioral problems of the child related to the technical or non-technical issue of the toothbrushing, such as the Down syndrome child has a low tone muscle, so they need modification of toothbrushing technique. And the DS child also show the sensory disorder, so the child might dislike the feeling of the toothbrush inside in the oral cavity or the taste of the toothpaste. And also it's common for the parents for the special kids to feel worried about their child's aggressive behavior during toothbrushing. So to build the good habit for oral home care for the child, it needs cooperation among the parents, dentists, occupational therapists. So for the conclusion, having interdisciplinary approach in planning dental treatment with Down syndrome child with the behavioral disorder is essential. So we reached to the end of the presentation. I will introduce our staff members. And this is, I would also like thank you to all the residents. And here are the reference. Thank you and terima kasih.
Thank you so much. Hold on. Yeah. Thank you so much, Dr. Amrita Widyagarini. A very good presentation. And we're still ahead of our schedule, actually. And the last presentation, we will have Dr. Mitsuku Chiba from Kyushu University. And he will present the dental treatment of children at Kyushu University Pediatric Dentistry. As we know, Chiba Mitsuki Sensei is from Faculty of Dental Science Department of Dental Science Academic Researcher, and he has graduated from Tohoku University graduate and in 2017, and he's now the research fellow in the Kyushu University Hospital. Thank you so much for your time, and you may start your presentation, Sensei, for 15 minutes. Thank you so much.
Thank you for introduction. I'm Mitsuki Chiba. I work in this university as postdoctoral researcher now. And my major is pediatric
Sumimasen,
dentistry.
Sensei, could you please make your voice a bit louder, please?
It is okay?
More?
More?
Yes. Mochoto.
It is okay?
Yes, thank you.
Okay. Okay, and my major is pediatric dentistry, and this is my title of presentation. Dental treatment of children at Kyushu University Pediatric Dentistry. Actually, I came this university 2 months ago, so just today I just want to introduce our university treatment and treatment in Japan. Today I bring these two topics: pediatric dentistry treatment in Kyushu University Hospital and developmental insufficiency of oral function. First, I will show about our hospital and treatment comparing other dentists. So in Japan, the caries patient is decreasing. And this graph shows the prevalence of dental caries in Japanese children. The number of rate is decreasing each year. Over the past 3 years, 3 to 5 years old children's caries rate has dropped under 10%. The rate number of caries-free 3-year-old children is almost 90%. From this data, some people told their opinion like pediatric dentistry is not popular in the future, especially in caries treatment. This slide shows the rate of caries cases in 3-year-old children in 2022. In Tokyo, the prevalence of dental caries among 3-year-old was approximately 5%. However, in Fukuoka Prefecture, where Kyushu University is located, the rate about 9.5%. Furthermore, in the Kyushu region, the number of caries children is very high compared to the rest of Japan. So the caries treatment for children is still very high, still very necessary, especially in Kyushu area. In Japan, most of pediatric dentistry belongs Japanese Society of Pediatric Dentistry. The number of dentists in Japan is not low, it's almost 100,000. However, the number of the JSPD members is only about 5,000. And the number of specialists is only 1,200. It's very low. Pediatric dentists require a variety of expertise and skills like rubber dam technique, occlusal guidance, and treatment of trauma. Some of young children are not cooperative and sometimes have problem of development or disease. So we might have to use behavior control technique to patients. Sometimes we get the situation that we do treatment in general anesthesia. Many general dentists do not have this knowledge and techniques, so the demand for pediatric dentists is still high these days in Japan. This conversation like dentist says he's too young to treat caries, so let me observe applying silver diamine fluoride until getting cooperation. And mother says okay, but she's not really convinced. I suppose this situation is still common in Japan. This is our hospital. We have outpatient area and inpatient area. In our outpatient area, we can do general treatment and restoring treatment, and also we can use nitrous oxide. If the patient doesn't have severe disease, we can use this inpatient area for general anesthesia. Last year, general anesthesia case was 270 cases, and almost all of treatment was caries. This case number is not common in Japan, so we can say this is the character of our pediatric dentistry. In Kyushu University, there is Children's Medical Center. In the center, pediatric surgery, and pediatric dentistry belongs. Related departments provide multidisciplinary medical care for children across the medical departments. We also actively introduce new treatments for pediatric cancer and participate in clinical trials. First, the patient is hospitalized in the pediatric departments before any chemotherapy or other treatment is given. The patient is referred to our department for examination of the caries. The patient is taken caries treatment, and oral intervention is provided with the dental hygienist. And then surgery performed. During hospitalization, oral management is performed on a regular basis. After leaving from the hospital, patients continue to be managed in the departments. Here I show the case of the patient. This patient had severe caries in Hotis, but he was not cooperative, so treatment was delayed at general dentist, just only applying silver diamine fluoride. So we have decided to treat caries under general anesthesia for this patient. Some molar and upper incisor teeth got pulpectomy and crown. And other caries are filled composite resin. And after extraction, two band loops are fit on upper molar. And now he came to our department for follow-up. This is another patient. She was 16 years old and chief complaint was caries. She also had odontophobia, so we planned the general anesthesia treatment. But she also had a problem in medical history. Because of the possibility of pneumothorax recurrence during dental treatment, it was performed in the medical operating room. The surgery could be performed in case of emergency. Thanks to this medical center, we can handle such difficult cases. I believe this is the strength of our pediatric dentistry. Next, this is long-term follow-up case of acute lymphoblastic leukemia. He was referred us to check the oral condition before the chemotherapy. This patient had no problem, so we only do oral cleaning and sealant. After the chemotherapy, this patient achieved a remission, and we kept following up. 2 years later, he had a pain in left molar, left lower molars. So he got to see a general dentist, and he was told that is a periodontitis or wisdom tooth. And we could see the swelling in the part of left lower wisdom tooth and shadow around the wisdom tooth in this X-ray. Although blood test had no problem, but without this is a recurrence of ALM, so we ordered doctor the MRI scanning. Finally, they found the tumor in left side of face and diagnosed the recurrence. From this case, we can start the treatment immediately, so the connection of our center is very important. Unfortunately, we did the best, but the patient was died. However, with both, it was good to realize recurrence immediately, thanks to this center. This is our first topic. Then I finish this topic, move to another one. Next, I talk about developmental insufficiency of oral function. In recent years, the declining of oral function in children has been a problem in Japan. This is a posture of attention of that. For example, slow eating. On the other hand, fast eating without chewing, and finger sucking, and opening mouth. Some children can blow out a candle because of a decline of oral function. This is an image of the changing in oral function with aging. The requirement of proper oral function during childhood is also important for the maintenance of oral function in adult. It is also important to improve the function against the decline of it in old age. It is suggested dental intervention is needed in each stages. So pediatric dentistry, we should check this part before school age. However, what should we do for them? There was so many ways to there's so many way and unclear. Then I show the workflow in Japan. First, we check their problems of oral function using this table. We can check problems of eating, speaking, and other. This is A part. And more detailed classification is B and C part, like delaying of eruption, malocclusion, caries, tongue-tied, and problem lip closure, and more. If we find patients have any problems, we do some tests that measures lips and tongue pressure. Then we do training. This training is designed for each patient, and that results are evaluated every few months using that checklist. Training may be performed by a dentist or a hygienist. Sometimes it will be done by a speech-language pathologist. Some of the tests are covered by insurance in Japan, and we believe that oral malfunction training will continue to develop in the future. Of course, in our hospital, we also planning to do this oral malfunction treatment when we find the problem in children. However, the number of the cases is still not so many, and we have other patients so many. It may be difficult to use these tools now. If we get some opportunity, we will do this treatment. Okay, this is finished. This is all for my presentation. Thank you for listening.
Thank you so much, Sensei. Very, very nice presentation. And we've come to the last session. We will have the questions and answer session will be conducted by Dr. Oki Fadila. And Dr. Oki Fadila is from Oral Biology Division, Faculty of Dental Medicine, Universitas Erlangga. And she will be she will conduct this session until 10:27. Dr. Oki? Okay, thank you. The time is yours.
Okay, thank you, Dr. Sari, and thank you for all the presentation, an amazing presentation. Now we will have a question and answer session. You can raise your hand or type on the chat box, so I will help you to read it. And there is already one question. I think this is for Dr. Mitsuki Chiba from Kyushu University Hospital. The question from Dr. Devi. May I ask, for patient 5 years old with heart disease, high caries in preparation for cardiac surgery, need to extraction 8 until 10 teeth before cardiac surgery. And the question is, when is it the best time to do the teeth extraction, 1 week or 1 month before? And when should the best time to give the patient space maintenance? While now the permanent molar hasn't appeared. What type of space maintenance the best for this uncooperative patient? So, Dr. Mitsuki Chiba, the time is yours to answer the question.
Thank you for the question. First, the time for extraction. I think it's 1 week before is 1 week is good because maybe she or he patient has the medicine. It's not I think whichever if he has a medicine for the heart disease. And when should the best time to give the patient space maintenance? Okay. Before eruption, the molar, I think I use the RSM removable type of space maintenance for this patient first, and after eruption, we change the lingual arch. It is okay.
Okay, so how about the answer, Dr. Devi? I think that's clear, or do you have another question? Okay, so I will repeat Dr. Mitsuki Chiba answer. So 1 week before is the best time for the extraction, for the teeth extraction, and removable is first choice. And if already eruption, we will move to another type of space maintenance. Okay, we move to another question for Prof. Sabri bin Musa. This question from Dr. Supeni. Do you suggest use fluoride application every 3 months for patient who is not cooperative and have molar hypomineralization?
Thank you for the question. The use of fluoride applications depends on the needs actually, and what types of topical fluoride that you use. If you use one is recommended not more than 3 months, every 3 months, not more frequent than that. And it depends on, if patient is not cooperative, there's no way you can apply the fluoride. Yeah, and the other alternative, you use the silver diamine fluoride, which is, but again, there's a pro and cons for every types of minimal interventive treatment to the patient, minimal intervention. So it depends actually. So with the hypomineralized and not cooperative, if it's difficult, then we could find another way of doing that. But if we cannot apply, then nothing much we can do for the patient. But we got to go back to the basic recommendation of fluoride intake or application for the patient actually. Am I answering?
Okay, thank you so much. Okay,
Right.
thank you so much, Professor. So it depends on the condition of the patient.
Yep.
Okay.
Then
Okay, we will move.
this assessment need to be done to see, how often this need to be delivered to the patient. Yep.
Okay, thank you, Professor. We'll move to another question for Dr. Amrita from Dr. Sufeni. Are there any tips and tricks for managing children who tend to have tantrum to help them develop good and proper toothbrushing habit? Excuse me, Dr. Amrita, we cannot hear your voice.
Okay, is my voice is clear? Okay.
Okay, yes.
Thank you for the question. So, basically, we need to find out what is the trigger that cause this child have a tantrum. So when we have the list, we can ask the parents when the child have the tantrum, what the child dislikes, what the trigger making his or her tantrum, and if we already have the list, so we can avoid those when we start to do the toothbrushing for the child. And also for the child who tend have a easily tantrum, we need to do everything in a short limit. So don't do like a dental examination in a long time. So we need to limit our time. So is that answer your questions, Dr. Sufeni?
Okay. Maybe Dr. Sufeni will have a response after this. Dr. Amrita, thank you so much for your answer. So the time management is a good way, Dr. Amrita, yeah. And we move to another question to Prof. Tania from Dr. Kiki Seila. As a clinician, for me, it's a quite tough, challenging when facing the case with blood disorder. What is the consideration to be highlighted most to minimize the recurrency? So, Prof. Tania, the time is here to answer the question.
Okay, thank you, Dr. Kiki Sela from Rumah Sakit Harapan Kita. So, according to your question, whether what is the consideration to be highlighted most to minimize the recurrence of the oral problem, the most important thing, according to my knowledge, is at first we should make sure what is the diagnosis of the oral problem, what is the specific disorder of the blood, because we know that several types of disorder of the blood, considering according to the related to the blood production or maybe the shape of the blood cell, or maybe the production, but then the destruction of the blood cell at first. So we need to make sure what is the diagnosis of the blood disorder. And the second, we need to build a good ally with the pediatrician or other specialists who has more knowledge to take care of the patient with the systemic disease. But most important thing is the prevention of the oral pathology, so we can prevent the more severe cases for the future for the children. I hope it will answer the question, Dr. Oki.
Okay, thank you so much, Prof. Tania. So the most important is the prevention action, yeah, Prof. Tania.
Yeah, agree, Dr. Oki.
Okay, thank you so much, Prof. Tania. Is there any time for the one question, Dr. Sari? Is it okay? Okay. Is there any question and you can want to give a question to the speaker? Actually, I have one more question from myself. I'm so sorry. This is for Prof. Tania. So this is my personality case from my
Oh,
child. So I have a 3 years old daughter, and at one time she have a regular drug, and there is no specific reaction. But sometimes, just one time, she have a reaction like EM. Is there any possibility if anyone first they have no reaction if consumption specific drug, but in another time she have an EM reaction? Thank you, Prof.
okay. Thank you, Dr. Oki. Yeah, it is possible, yeah, because as we know in our two cases present previously, that the previous medicaments or drugs considering related to antibiotic or the antihistamine has no effect on the children. But suddenly, occasionally, unfortunately, maybe because the immune system is dropped, and then the drug reaction is the trigger of the erythema multiforme. The most important thing is we have to distinguish what kind of the erythema multiforme that our patient or our children has, whether it is erythema multiforme minor with limited skin rash, or the major erythema multiforme with lots of skin rash, or only limited to oral erythema multiforme that has no skin rash at all. So we have to evaluate the history of the drug or any allergen previously, so we can find the trigger, we stop it, and we increase the immune system. And I think the erythema multiforme get healed by themselves, because this is actually the self-limiting disease, Dr. Oki.
Okay, thank you so much, Prof. Tania. That's very clear
You're welcome.
answer for me. Okay. Okay, Dr. Sari, have you any question?
Yes, one of the audience would like to ask questions.
Yes. Good. Thanks. Good morning. Morning. Is my
Yes,
voice?
good morning.
Good morning, Professor and Doctor. My name is Inaya, and I'm from Universitas Indonesia. I like to ask some question to Professor Tania. The first is about the home care aspect. How do you instruct the parents on managing the lesion at home, particularly on the treatment and how they eat for the diet, and also how do they maintain the oral hygiene during the recovery? And I'm also curious about the ointment used to treat the lesion. Was it commercially available product, or did you have it specially formulated in a pharmacy? Thank you, Professor.
Thank you very much for the questions. So the first question is how our instruction to manage the oral, what is it? The home, what was it? Sorry. Home
Sorry, home care
home-
instruction.
home care instruction. Okay. So for the home oral care instruction, since the patient has the blood encrustation and also the crusta, so we will ask the parent to do the compress and soak the blood encrustation with the saline solution 3 times a day. So the saline will soften the blood encrustation, so it will heal the dryness and allow the patient to eat more comfortably. And also about the dental health education, we still ask the parents to continue the daily routine oral dental health at home, yeah. So brush the teeth 2 times daily. Since the oral cavity was not included in the rest, so the rest only on the lips. But of course, when the patient open their mouth, it will feel very painful, and sometimes it will get bleed. And then the fourth question is, what is the prescribed ointment? So for the first patient, we make our own prescribed pulverus, because considering that the patient was received several treatments systematically, and that drugs or prescription, the previous prescription has led to the allergy for the patient and trigger the erythema multiforme. And I am sorry, I forgot what is the third question was.
Excuse me, I have only 2 questions.
Atau question?
Yeah, the second one is about the ointment. The
Ah,
one
yeah.
Vaseline and
Available itu.
yeah,
Yeah,
Available.
we,
the
we,
topical drugs you use.
okay. So since we were afraid to give them systemically drugs, so we suggest to give the topical only. But the topical ointment consists of the Vaseline to give the, the moisten the skin and the lips, and also contain the antihistamine and also anti-allergy. So it just this is only the the adjuvant therapy. This is actually not the main therapy, since the main therapy of erythema multiforme, since it is a self-limiting disease, so the immune system will help the erythema multiforme to heal. Is it answer your question, doctor?
Yes, thank you, Professor.
You're almost very welcome.
Okay, thank you for all the question and answers. So I think the time for this session is
You still have one more question if you want
one
to.
more question.
Yeah.
Okay.
Until 27, Dr. Okay.
Okay, Dr. Sari.
Good morning. This question is for Prof. Tania also. Um, Professor, is doing blood work or laboratory work up indicated as a standard to diagnose, or is it only for severe cases to rule out other diagnosed? And is allergy testing to certain drugs indicated to rule out the drug that creates these flare-ups? Thank you.
Okay, may I answer directly? Okay, so for the first question, are there any specific or guidance for the laboratory work? Actually, we know that the erythema multiforme is the self-limiting disease. So we let the body immune system heal the pathology, the pathology systemic pathology condition. We give only the adjuvant therapy, but if the erythema multiforme or maybe the pathology is get prolonged, for example, in my first patient, so we suggest to check the complete blood count, and we check the nutrition of the patient, because we know that the anemia is the cause. Anemia and malnutrition is the one of the cause of the prolonged wound healing. So we check that parameter. But actually, we do not need to refer the patient to have the laboratory or serologically examination. And also for the, for example, the IgE or the other serologically examination, we were not suggested to have that analysis for the routine work, because as long as we can get the history of the previous medicament or the previous condition of the patient, by stop or by by stopping the prior medicament, and if the response is already okay, so we don't need a further analysis. And what is the second question? Sorry.
Second question?
Is it?
It's about the allergy testing to certain
Oh,
drugs.
yeah. Yeah. Okay. So actually, for our second patient, we was tempted to check the allergy test for the children, but since our simple treatment was already get the good response from the patient, so we didn't continue to check the allergy. As I presented previously, the second patient has a very good recovery in only 5 days. So the patient didn't want to come again to the hospital, and the parents only sent us the picture by the mobile phone showing that the children is already get relief of the erythema multiforme.
Thank you. Thank you, Prof.
You're welcome.
Okay, thank you, Prof. Tania, for your detail of your answer. So I think our time is up for answer and question. I think this is very interesting question. So maybe there is some of us want to ask question. We can send an email to our presentation, to our presenter, and I will give it back to the main session to Dr. Sari. Thank you.
Thank you so much. Because of our limited time, we have to close this very interesting session. Hope to meet you all again. Before that, we would like to show our gratitude to our organizer, Dr. Aksa Shuhada from Universitas Erlangga, And thank you so much for the Chief Engineer Saori Matsuda-san from Kyushu University and Chief Engineer Mr. Tunggul Laksono from Brawijaya University. Thank you so much for your support, and thank you so much for everyone, especially our presenters. We are very happy and very grateful to have you all to be our presenters today. We hope to see you again in our next section next year, and hope to all of us will always be healthy. Thank you so much. Have a lovely day. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much,
Thank
Doctor.
you. Thank you, Professor Musa. Thank you, Professor Tania.
Thank you,
Musa.
Dr. Alfa,
Thank
Dr.
you, everyone.
everyone.
Thank you, everyone.
Uh,
Thank you, everyone.